Ulcerative colitis. Ulcerative colitis is a recurrent ulcerative and inflammatory disease of the mucosal and submucosal layers of the colon and rectum. It is a serious disease accompanied by systemic complications and a high mortality rate. Eventually, 10 to 15% of patients develop carcinoma of the colon. Pathophysiology. Ulcerative colitis affects the superficial mucosa of the colon and is characterized by multiple ulcerations, diffuse inflammations, and desquamation or shedding of the colonic epithelium. Bleeding occurs as a result of ulcerations. The mucosa becomes edematous and inflamed. The lesions are contagious, occurring one after another. Abscesses form and infiltrate is seen in the mucosa and submucosa with clumps of neutrophils in the crypt lumens, that is crypt abscesses. The disease process usually begins in the rectum and spreads proximally to involve the entire colon. Eventually, the bowel narrows, shortens, and thickens because of muscular hypertrophy and fat deposits. Clinical manifestations. The clinical course is usually one of exacerbations and remissions. The predominant symptoms of ulcerative colitis are diarrhea, lower left quadrant abdominal pain, intermittent tenesmus, and rectal bleeding. The bleeding may be mild or severe and paler results. The patient may have anorexia, weight loss, fever, vomiting, and dehydration, as well as cramping, the feeling of an urgent need to defecate, and passing 10 to 20 liquid stools each day. The disease is classified as mild, severe, or fulminant depending on the severity of the symptoms. Hypocalcemia and anemia frequently develop. Rebound tenderness may occur in the right lower quadrant. Extraintestinal symptoms include skin lesions, that is, example erythema nodosum, eye lesions, example uveitis, joint abnormalities, example arthritis, and liver disease. Assessment and diagnostic findings. The patient should be assessed for tachycardia, hypotension, tachypnea, fever, and pallor. Other assessments include the level of hydration and nutritional status. The abdomen should be examined for characteristics of bowel sounds, distension, and tenderness. These findings assist in determining the severity of the disease. The stool is positive for blood, and laboratory tests results reveal a low hematocrit and hemoglobin concentration in addition to an elevated white blood cell count. Abdominal chest X-ray studies are useful for determining the cause of symptoms. Sigmoidoscopy or colonoscopy and barium enema may show mucosal irregularities, focal strictures or fistulas, shortening of the colon, and dilatation of the bowel loops. Endoscopy may reveal friable, inflamed mucosa with exudate and ulcerations. CT scanning, magnetic resonance imaging, and ultrasound can identify abscesses. And perirectal involvement. Leukocyte scanning is useful when severe colitis prohibits the use of endoscopy to determine the extent of the inflammation. Careful stool examination for parasites and other microbes is performed to rule out dysentery caused by common intestinal organisms, especially Endamoeba histolytica and Clostridium difficile. In acute ulcerative colitis, cathartics are contraindicated when the patient is being prepared for barium enema or endoscopy because they may exacerbate the condition, which can lead to megacolon, that is excessive dilation of the colon, perforation, and death. If the patient needs to have these diagnostic tests, a liquid diet for few days before radiography and gentle tapeworm enema may on the day of examination may be prescribed. Colonoscopy is contraindicated in severe disease because of the risk of perforation. Complications of ulcerative colitis include toxic megacolon, perforation and bleeding as a result of ulceration, vascular engorgement and highly vascular granulation tissue. In toxic megacolon, the inflammatory process extends into the muscularis, inhibiting its ability to contract and resulting in colonic distension. Symptoms include fever, abdominal pain and distension, vomiting and fatigue. Colonic perforation from toxic megacolon is associated with high mortality rate. If the patient with a toxic megacolon does not respond within 24 to 48 hours to medical management with nasogastric suction, intravenous fluids with electrolytes, corticosteroids and antibiotics, surgery is required. Total colectomy is indicated. For many patients, surgery becomes necessary to relieve the effects of the disease and to treat these serious complications. An ileostomy usually performed. The surgical procedure involved the care of patients with this type of fecal diversion are discussed. That is 3 types. One is total colectomy with ileostomy, total colectomy with continent ileostomy, and total colectomy with ileoanal anastomosis. Patients with irritable bowel disease also have a significantly increased risk of osteoporotic fractures due to decreased bone mineral density. Corticosteroid therapy may also contribute to the diminished bone mass. Medical management of chronic inflammatory bowel disease. Medical treatment of regional enteritis and ulcerative colitis is aimed at reducing inflammation, suppressing inappropriate immune responses, providing rest for the diseased bowel so that healing may take place, improving quality of life and preventing or minimizing complications. Most patients maintain long-term well-being interspersed with short intervals of illness. Management depends on the disease location, severity and complications. Nutritional therapy, oral fluids and a low residue, high protein, high calorie diet with supplemental vitamin therapy and iron replacement are prescribed to meet nutritional needs, reduce inflammation and control pain and diarrhea. Fluid and electrolyte imbalances from dehydration caused by diarrhea are corrected by intravenous therapy as necessary if the patient is hospitalized, or by oral supplementation if the patient can be managed at home. Any foods that exacerbate diarrhea are avoided. Milk may contribute to diarrhea in those with lactose intolerance. Cold foods and smoking are avoided because both increase intestinal motility. Parenteral nutrition may be indicated. Pharmacologic therapy, sedatives and antidiarrheal and antiperistaltic medications are used to minimize peristalsis to rest the inflamed bowel. They are continued until the patient's stool approach normal frequency and consistency. Newer sulfur-free aminosalicylates, example mesalamine, Asacol or Pentasa, have been developed and shown effective in preventing and treating recurrence of inflammation. Antibiotics are used for secondary infections, particularly for purulent complications. Corticosteroids are used to treat severe and fulminant disease. These corticosteroids, example prednisone, can be administered orally in outpatient treatment or parenterally in hospitalized patients. Topical, that is rectal administration, corticosteroids are also widely used in the treatment of distal colon disease. When the dosage of corticosteroids is reduced or stopped, the symptoms of disease may return. If corticosteroids are reduced, Adverse sequelae such as hypertension, fluid retention, cataracts, hirsutism, that is abnormal hair growth, adrenal suppression, and loss of bone density may develop. Hirsutism, Hirsutism. Hirsutism. Immunomodulators, that is azathioprine, Imuron, have been used to alter the immune response. The exact mechanism of action of these medications in treating IBD is unknown. They are used for patients with severe disease who have failed with other therapies. So first one is sulfur-free aminosalicylates, antibiotics, corticosteroids, and oral prednisone or rectal administration corticosteroids, immunomodulators, azathioprine. Surgical management. When non-surgical measures fail to relieve these severe symptoms of IBD, that is irritable bowel syndrome disease, surgery may be recommended. The most common indications for surgery are medically intractable disease, poor quality of life, or complications from the disease, or medical therapy. More than one half of all patients with regional enteritis require surgery at some point. The procedure of choice is a total colectomy and ileostomy. A newer surgical procedures developed for patients with severe regional enteritis is intestinal transplant. This technique is now available to children and to young and middle-aged adults who have lost intestinal function from disease. Although not a cure, this procedure may eventually provide improvement in quality of life for some who are terminally ill. Approximately 15 to 20% of patients with ulcerative colitis require surgical intervention. Indications for surgery include lack of improvement and continued deterioration, profuse bleeding, perforation, stricture formation, and cancer. Surgical excision usually improves the quality of life. Proctolectomy with ileostomy, that is complete excision of the colon, rectum and anus, is recommended when the rectum is severely involved. One type of surgical technique that can be helpful in strictureplasty, in which the blocked or narrowed section of bowel is widened, leaving the bowel intact. If a lesion can be delineated in regional enteritis, or if a complication has occurred, the lesion is resected and the remaining portions of the bowel are anastomosed. Surgical removal of up to 50% of small bowel usually can be tolerated. Other types of surgical procedures are: one is total colectomy with ileostomy, total colectomy with continent ileostomy, and third one is total colectomy with ileoanal anastomosis. These procedures are known as fecal diversions. Thank you.